philosophy. She's a bioethicist, and she promotes bioethics in all aspects of medicine. And today she'll be talking about, in the context of pre-exposure prophylaxis, which has been approved several years ago to provide as a prophylactic strategy to people who are high risk but not HIV positive. So within the context of PrEP dissemination, where ethics comes in, and she'll be shedding some light in this very important topic. And I'm still waiting to get her talk. So maybe you can just tell the audience briefly about yourself, and then hopefully your presentation will arrive.
If it doesn't, it's okay. We can work without it. It's all right.
Okay.
So, welcome. Thank you for being here. As mentioned, I'm an ethicist, and so my area of research is in philosophy of science and ethics, and where the intersection of the applications of science, and in particular emerging technologies in medicine and in research, sort of get ahead of the ethics. And so my job is to try to help the ethics catch up. And so there are a lot of areas where we often have asynchronous advancements in both legal status and in moral status work. And one of those areas that we're going to talk about today is the use of PrEP, and how to think about this new technology and this new intervention with HIV prevention, and have applications in ways that we haven't had to face ethical questions before. So I'm happy to get started, or we can see if we're going to call it on the PowerPoint. This is the nice thing about being a philosopher, is that we're new to this PowerPoint business. We're used to togas and chalk.
Started, and then I'll try to get your talk.
Sounds good. So here's the purpose of today's talk. Here's where we're going to be focusing. So I want to be all on the same page and give you sort of a high-level intro to where the ethical questions are, the things that people worry about the most in regard to PrEP. And then we're going to focus on one in particular that is probably getting the most ink, the most concerning, the most debate. And I'm going to give perhaps some thoughts on how to answer this question, or at least a new way to approach it. My goal is to end with enough time for questions so that we can discuss it together. So before we start talking about the use of PrEP as a new innovation, as a new therapeutic application, let's get a few facts about it on the table. So these are a few things that are relatively non-controversial as we talk about this technology. So the first, of course, is that the technology is relatively effective. So there's a lot of good studies right now that have been done in all sorts of demographics, all sorts of populations all around the world, that this actual pharmacological agent taken orally is extremely effective at preventing the transmission of HIV. Relatively high return. That's not a huge amount of money to pay for each of those additional years. Well, let's look what happens when we add PrEP. So we add PrEP, and this is to try to get to approximately 60% coverage for women who are especially at high risk, ages 20 to 29. We tend to focus on this demographic when we talk about PrEP because one of the things we're worried about, of course, is women in childbearing years. And so we're worried about people who are going to be then transferring potential infection to their children. So we add PrEP, and now we look to per infection averted. We have 7,200 over a 10-year period, 5,800 over a 20-year period. Now, you look at this, and these numbers are certainly higher than the earlier intervention, but it doesn't look that dramatic, the difference in numbers, until you start to look at the price per quality of life year. And all of a sudden, those numbers look very, very different. So when we start to look at what the overall life cycle cost of PrEP actually is, the problem is all of these studies involve a number of difficult and problematic assumptions. Before we even get into whether the numbers are accurate, we start with all kinds of really, really, really contentious assumptions before even gathering this data. So all of this is made on hypothetical assessments of how often people will adhere to this treatment program. So we have to make assumptions about what success looks like. Even if we give access to PrEP, how often are people going to very seriously rely on the treatment schedule? How often are people going to get the required lab testing, and in particular kidney function? And how likely is it that lapses in coverage will prevent this overall reduction in HIV infection? So all of these numbers, even when we sort of build in best case scenarios, when people are extraordinarily compliant with regimens and adhere to the schedule of medication very carefully, they're still far more expensive than many other treatments. That presents a challenge to us. So when we talk about how to distribute resources, it's not entirely clear if we have a limited pot, a limited amount of money, a limited amount of time, who should get what. Given that this technology is very new, thinking about whether we should invest in it, whether we should spend our resources, especially our limited resources, working towards that number when that number seems so much more attractive is an open moral question. And the truth, of course, is that this number might be far greater than it actually looks. So today we're going to talk about how to talk about money. Sometimes I joke that my day job is talking about all the things you're not supposed to talk about at the dinner table. So we're going to talk about money. Sometimes you can hear me talk about sex and religion, but today we worry about finance. So we're going to be talking about where the moral questions tend to come in the literature currently. And when we talk about how people worry about the ethics of PrEP, these are the discussion areas that tend to get the most focus. This is where the discussion up until now has been focused on 3 primary nodes. So we're going to talk about each of them, and we're going to talk about why the discussion hasn't been settled on each of these primary nodes and what we can do hopefully to further it. So before we move forward, we're going to start talking about how it is we do ethics like this, right? What is the goal? How do we actually work out these questions? Well, here's what we can't do. We can't do something simple like, well, obviously we go with whatever is most cost effective. The reason we can't do that is because guess what's maximally cost effective? Treat no one. Let them die. Right. So perhaps we have a slightly different goal than saving money. Our goal is to do something else. So when we speak about utility, often how utility is translated in literature from ethicists to non-ethicists looks something like this. It looks like saying, do the benefits outweigh the harms? That's actually an extraordinarily inaccurate way to discuss what utility looks like. A more accurate way to talk about what this task is, what we mean when we talk about utility, is how effective is this particular option at meeting whatever it is our goals are. So our goals are extremely straightforward. We're trying to reduce the number of HIV infections and stop an epidemic. That's the goal. The question is, what's the most effective way to get there while also not being extraordinarily short-sighted? And by short-sighted, I mean, of course, we could stop the epidemic by killing all people with HIV. And yet, right, the whole point of utility is it doesn't stand alone. It has to be located in a larger ethical construct of why it is we're here, why we care about seeking out cures for epidemics that decimate populations. So we have to talk about what to do next. Now, currently, when we talk about cost-effectiveness literature, people who work on this field and people who do all sorts of modeling, especially economic and math modeling about what the costs of PrEP might look like, have come to the following conclusions. So people suggest that PrEP is probably cost-effective in the following circumstances, and only in the following circumstances. In resource-rich nations, the US, Canada, the UK, etc., with resource-rich patients who are already at high risk. That tends to be the only cases where the numbers come out in our favor for making this the most cost-effective option. What that means is that for the vast majority of people who are in underserved regions, the vast majority of people who live in non-resource-rich areas, well, the math doesn't come out in their favor. What you see is right now, activist groups all over the world vocally demanding access to this technology. The question is, do they have a right to it? Should we think about something beyond the math, beyond the economics? Are there things we need to think about? And the answer, of course, will be yes. That discussion has not happened sufficiently, so you and I are going to have it instead. What hasn't happened in the literature yet is to talk about how to do something beyond just calculating the cost. After all, if we just did that, we would all go home. It's expensive to practice medicine. We do it because it's worth the money. It's important. So our job is to figure out, beyond expense, is it worth it to put this resource in if that will be a direct cutting from some other resource? Now, what we mean by direct cutting from some other resource, of course, is if there's a limited amount of money and resources to spend on HIV and its treatment and prevention, then what we're doing is stealing from Paul to pay Mary. What we would be doing is taking resources away from the treating of people who are already infected and perhaps who are near death, or at the very least would be if they didn't continue to get treatment. What we're looking then is at a far more complicated ethical question. We can speak abstractly about rights, that we have an abstract right to aid, an abstract right to rescue. The problem is none of us can be in more than one place at a time. And so there's a common moral dilemma that we talk about if you're one person and you see two people drowning, and who do you save? And we can talk about, well, I would save the person who needs my help more, the person who I know, the person who's younger, the person who's fill in the story. And we argue what criteria should be used. But it's important to recognize that that's precisely the situation that we're in. So here we are at the edge of the lake, and we have two people who we can save from drowning. The question is, one option is the person who has not yet been infected. And the other, of course, is someone who already urgently needs our help. Now, this is not an easy question, given that we cannot save both. And that's the dilemma. Now, I want to state explicitly that just because it may not be the most cost-effective way to go to use PrEP does not mean that the moral question is settled. There are many times we may be obligated to do the thing that is not the most cost-effective. So instead, we need to discuss, how do I decide to save who's drowning? But the important thing to realize is that this is going to involve going against, or at least questioning and evaluating, some of our foundational commitments when it comes to the practice of medicine. So when we talk about basic questions like triage, if you think about how to treat patients in an emergency department, one of the first standards of care that you're going to focus on is, who is more at need? Well, there is no question here, who is more at need? The person who is already infected and requires therapy today, they are more at need. The question is, how much moral weight should that hold? So we'll talk about that. Of course, we also have, in the literature, what is sometimes referred to as rippling benefits. So let's remember what our goal is. Our goal, of course, is to treat individual patients, but our goal is actually to do something much larger. We're trying to shift effects on a population level, and we're trying to change how this infection spreads, not just from individual to individual, but from all of us. What that means is that now when I do math, my concerns are not just comparing person A to person B. My goal is to think about what's going to further my end of trying to change the shape of this epidemic. And that may look different than choosing how to treat one individual versus one individual. So that's the task. We're doing nothing less than deciding who to save when there's multiple people who deserve to be saved. And that may or may not correspond with what the economic assessments look like. So let's talk about how to do it. So thus far, much of the ethics that we discuss, much of what happens in the literature stops at that moment. They stop by saying, it's tricky, we have to balance competing good, and then people take a bow and they leave the stage. That is perhaps one of the greatest sins of my discipline. We say, here are things that need to be measured, you should do that. What we don't say is, how do we do that? Let's walk through and see what that looks like. So together, that's precisely what we're going to start discussing. So one of the ways we're going to do that is we're going to shift the conversation away from sloppy discussions of utility. We're going to do that by removing the discussion from what we call the aggregate. So one of the reasons that most academic ethicists, most people in my line of work, do not use this utility talk. There's a large disconnect between how people in academic ethics work on problems like this and how that gets filtered out into the world. One of the reasons we don't talk like this is because it turns out that there's a huge bit of information that gets lost when we discuss utility. And that's because when we discuss overall utility, balance of harm versus benefit, it turns out what we're doing is taking the aggregate collection of how things work, and we're coming out with a sum on top. Here's the problem when I take the aggregate. Whenever I take the aggregate of on balance, harms and benefits, what I'm not taking into consideration is who particularly is benefiting and who particularly is not. What that means is that when I'm doing nothing other than taking the aggregate and looking at utility, I'm unable to make a distinction between, say I can save 4 patients over here or 1 patient over here, and I choose the 4, versus I can save these 4 patients by cutting up this 1 patient and redistributing organs. If I'm just looking at the aggregate, those two look identical. 1 dies, 4 get saved. And yet important data has been lost. And that's, of course, that I don't actually have the moral authority to be redistributing organs. So, in this case, how do I move away from the aggregate? Well, I need to start to talk about what's interesting about PrEP. And what's interesting is that for the first time now, we have a technology that helps a certain demographic that has not historically been able to be served in this way. So let's talk about what the population looks like who is most benefiting from technologies from PrEP, like PrEP. And we're going to do that by talking about what it means to work with vulnerable populations, and in particular, to work with notions of justice. So in particular, here's the groups that benefit the most with technology like PrEP. The population that is traditionally least able to use technologies like condoms to prevent the spread of HIV, sex workers, women, and infants who get infections from their mother. These are the groups that don't have access to the use of other HIV prevention technology. Children, of course, but women and sex workers for reasons that are very particular. The reason that these demographics don't have the same kind of access to, say, condoms or other behavioral interventions is because we have these two groups that are extraordinarily of systemic disadvantage. You have groups that are unable to negotiate the use of technology like condoms because, after all, they don't have the social power to do so. So what does that mean? Well, let's talk about bringing the particular out of the aggregate. Let's talk about what it means to work with vulnerable populations. So one of the ways that we frame these questions, we worry about questions around justice. And what we mean by justice isn't an abstract concept. Again, a lot of these words are used in extraordinarily rhetorical ways. Like, I have a joke, it's about justice, beneficence, and fiscal responsibility, right? And these things as if they mean nothing. Well, justice is actually a very technical concept, and here's what we mean. We mean justice is a way to distribute resources in an unbiased, objective, fair way. Well, what's fairness? Well, here's what we think. So here's a classic Rawlsian thought experiment. So John Rawls was a philosopher who lived fairly recently, who worked a lot on questions of resources and how to think about how we should distribute limited goods. And he said, let's talk about how to make an unbiased decision. Well, here's what you do. Step 1, remove all conditions that are bias generating. What are those? They're things that are morally arbitrary about you. None of us choose our race, our gender, our nation of origin, our wealth. We get those things primarily through luck. Well, I can't choose to give those up. And so how do I make decisions based on where I live versus where other people do? Well, here's what he suggests. Imagine the kinds of decisions you would make if you didn't know where you fit. Imagine that you were vulnerable to being in the same populations. what are the distributions that we could agree on if none of us knew which end of the pie we would end up with? This is the same kind of general theory that at birthday parties, if you have children, I have 5-year-old niece and nephew twins. They have a piece of cake. You say one of you can cut it and the other gets first pick, right? You've seen this before. Fairness is having choices where no one is exploited. We often call this working with the most vulnerable population maximizing the minimum position. What that means is that the people in the minimum position, the people who are worst off, certainly didn't choose to be there, and neither would any of us. What that means is that one of our first and primary obligations is to make sure that our advances don't happen on the back of that population. So let's talk about what that means for PrEP. So it's true that when we talk about PrEP, it is less cost effective than other kinds of innovations. It may be less cost effective than increasing programs that have to do with, say, home HIV testing and counseling. But what it does is it helps one very particular vulnerable group. And it's a group that right now, the HIV epidemic is happening on the backs of. And for that reason, the ethics of this technology are extraordinarily unique. Using this is one of the first ways that we can start to shift what has been a systemic power imbalance. And that's worth talking about. So now, instead of just talking about whether this is cost effective in the abstract, what I have to do is think about what my obligations are to this particular group. Groups that have already been marginalized and are already vulnerable. And that means having a discussion about the fact that it may be the case that I owe more care to certain sorts of marginalized groups than I do to groups that are less marginalized. So before we start talking about that, and I want to have room for questions, I want to have a discussion about what is one of the other controversies that has traditionally been worried about when it comes to PrEP literature, an area where people have often offered a lot of concern. So we're going to talk about what this moral question looks like and also why it represents something deeply troubling when we talk about how to do ethics on population level. So when we talk about compensatory behavior, here's what people have expressed concern about. The idea is if we distribute something like PrEP, something that is a prophylactic, then what we would be encouraging is the use of an increase of risky behavior. And in particular, perhaps a decrease in use of condoms, perhaps an increase in use of sharing needles, things that we think might put us at risk for an increase of population-level infection, or at least an eroding of progress. The idea is when we use technologies like this, are we giving people permission to do self-damaging and perhaps society-damaging behavior? Here's how this question has traditionally been answered, and here's how you and I should perhaps start to think about it. So step one, we'll talk about how this question is treated. Primarily, how people answer this question is through empirical studies. So they say, let's try it. Does this increase the use of either self-destructive or population-destructive behavior? If yes, problem. If no, no problem. All right, well, here's what that leads us to. So it turns out there is some preliminary data. Of course, PrEP has not been used for very long, but from what we've got so far, the preliminary data is that PrEP does not increase any sort of compensatory behavior. It does not lead people to engage in riskier sex. It doesn't encourage people to engage in new use of shared needles, etc. Now, there's a few problems with this data, though. The first problem is that who has already been given PrEP? Well, it's populations who are already engaged in high-risk behavior. Overwhelmingly, that's been the population who's been given access to this. So the fact that there's not an increase in the risky behavior may perhaps be misleading. After all, if there's a population that's already doing the thing that we're worried about, then there's a way that what we're showing is just about minimizing risk. Okay. That doesn't tell us, however, what it would look like at the general population if we started to use this technology at a far larger scale. So what would happen if we started to use this for populations that are not currently engaged in high-risk behavior? Well, people worry about this from an epistemic level. They worry about how can we know, how can we tell, is this too dangerous, etc. I want to suggest that we need to be very careful thinking about questions like this, and indeed perhaps we should not allow those kinds of questions to influence our choices on whether to use PrEP or not. So there are parallels in the history of medicine and the history of science when these questions have been asked. One of the most famous times this question has been asked in extraordinarily worried ways was with the invention of hormonal birth control. Indeed, there was a great moral panic when it came to hormonal birth control, that the release of this technology would lead to all kinds of unsavory behavior on behalf of loose women. Now, we look back at this, and hopefully we laugh, but the truth is, all of us are vulnerable to the bringing in of social value and the bringing in of moral judgment when it comes to the practice of medicine, either at the individual clinical level or at the population level. When we entertain discussions like this seriously, and we start to think that perhaps that people might increase or change their behavior to include riskier behavior if we give them this technology, what we're doing is we're endorsing the idea that this technology should be used as social control, something that we do to alter people's behavior. Now again, that sounds lovely if your goal is just to stem this infection, but our goal is not just to stem this infection. Our goal is to stem this infection with moral limits. Becoming social controllers and the importers of value when it comes to doing this kind of work comes with very dangerous territory. And in fact, this kind of paternalism is going to turn out to be deeply ethically problematic. So what I want to suggest is this when people start to talk about PrEP and compensatory behaviors. Now, it's true that so far, the results look promising, that no compensatory behaviors are happening, although that data may be not so helpful in our judgment of that fact. I want to suggest that the particular data can inform how we continue to treat populations, but it should not inform whether it is we continue to use this technology. Using this technology and holding populations hostage for value reasons, that's not our job. So that's where we stand. The goal then is this. For the rest of our time, I want to hear your thoughts, and I want to hear questions and comments, and thinking about challenges that you find when it comes to the use of this or other technologies, and how to balance who to save when they're drowning. Let's talk about how to do ethics on a particular level with particular populations instead of at the aggregate. So thank you. Thanks for hanging out with me.
So we have at least 10 minutes, and people can stay longer if they wish to. Some of us have to take random rules, but questions for Tiffany?
Please.
Maybe I'll start it out. One of the things that I find so valuable is to have some language that can be used to communicate. And so, I analogized in an earlier discussion PrEP to needle exchange.
It's exactly what it is.
From the vantage point of, are there what you would call, I love the term compensatory behaviors. Am I interpreting
Yes,
that term?
that's right.
Right. And so I'm broadly speaking, I'm just wondering, do you find that by, giving labels and language and clarifying the zones where there are apt to be agreements and disagreements, do you find that that you have effectiveness at resolving conflicts, or does it just more clarify the zones?
No, a huge part of my job is what I end up finding is that where people find that they're at an impasse and people aren't sure what to do, frequently that's a problem with language. What's happening is people aren't aware of exactly what it is that they're wrestling with. And so part of my job is helping apply content, right, beyond kind of shallow analysis. And once you start to add that content, it's a lot easier to figure out which direction is actually the right one. And so much of my work is helping people solve their problems. And I, of course, have my own research, but I would say probably 30% of my day job is working with people on whatever it is they do and trying to put a frame on it from where I come from on how to make decisions. So one of the things I find, and I work with med students and pre-med students, is that we often send people out into the world as scientists, as clinicians with so much technical knowledge, but we haven't given people enough preparation in how to think about when to use it. And so part of what people like me hopefully help with is filling that gap, giving the right kind of tools to actually make progress in problems. That's the goal anyway. Yes?
So thank you for your talk. I think it's really appropriate as we have a large adolescent trials network grant starting up in July here at UCLA, and we need to think about some of these things. So one point that you made that I really liked, got me thinking, was when you talked about where PrEP is most applicable, you know, in settings where there's more resources on the patient and provider side, and I was thinking, in some situations that's really clear cut, but I can see how even in the US, there's a whole spectrum of, you know, how do you decide, even in the US, some people have access to more resources than others. And
Oh, yes.
we have resource poor settings here too, in our backyard. And so I was just thinking, I don't know, it seems like that's a really difficult.
So there have been people who have made the honest suggestion that we shouldn't give PrEP to populations here who don't have robust health insurance, who cover PrEP. And then there's been another suggestion to not give PrEP to Americans who don't have medical coverage for follow-up labs. And the idea is, even if we make that kind of lab monitoring available for low cost, that people are far less likely to keep up with that kind of care and monitoring if they don't have reliable and robust insurance. So what's happening in those discussions is people are pointing back to the cost effectiveness. Do we lose people sometimes through lack of adherence and follow-up? We absolutely do. And does that put them right back at high risk? Yes. Does that mean that we should not use the technology with them? No. And that's the problem, is that we've started to interweave questions of cost effectiveness as if that's the end of the story. That's a hugely important part of the story, but it is not the only part that we have to worry about. And so, of course, it may be the case that we owe vulnerable populations, even here in the US, more priority in the use of this technology. And that's part of the work we aim to do.
So just to kind of continue with your comments about not looking in terms of aggregate, but looking at certain vulnerable groups of communities, even in the global setting. So when I first kind of learned about the PrEP, the mindset I had was, you know, obviously we shouldn't think of it as for everybody, but you know, we've made so many advances in HIV care and prevention and treatment, and I think we should look at PrEP as one of the additional tools
Exactly.
available.
Exactly.
And I think for certain populations like sex workers, condoms and HIV testing and treatment, they're not available, so it's not an option for them. So for them, it might be more appropriate to, even though it might cost more, to provide PrEP. Because,
Exactly.
you know, if prostitution is criminalized and if they get caught with a condom and they get put in jail, then condom is not an option. But if PrEP is an option, that might be more cost effective for them to use PrEP.
Exactly.
Whereas an affluent young gay man who's got access to HIV testing and treatment and, you know, condoms, PrEP is just an additional tool for them, but it may not be used in the same kind of manner in terms of protecting.
Exactly. Exactly. And that's exactly what gets lost when we just look at that chart in the aggregate.
Right. And then the comment about the, you know, compensatory behavior, I think, so Tom mentioned needle exchange programs, and, you know, obviously they proved that it's not, you know, I think drug use is an addiction, so people don't go around and taking up drug use behavior just because there are more clean needles available. It's more, and it's shown time and time again it doesn't increase drug use. And just everyday life, like people, we get flu shots because we want to, you know, prevent ourselves from getting flu. Just because we get flu shots doesn't mean that we go around and exposing ourselves with people who are coughing just to see if we get flu, right? So
Exactly.
I think this behavior disinhibition or compensatory behavior, I think it's sort of, that concern is sort of unfounded when it comes to PrEP. And I think the empirical studies also prove that, but if you kind of go beyond that, I think it's kind of, not an issue that we should really focus on.
Exactly. Well, there's something seductive about talking about questions like this because, of course, we're used to working on questions of empirical effectiveness, right? And so this idea of population behavior is part of the picture. But the question is our role to treat people or is our role to change behavior beyond giving positive incentives? And the answer is our job is not to coerce. And the choice to give or to pull away medication as a reward for certain behaviors, and that's what the reduction of the use of PrEP would be if we did see an increase in compensatory behaviors. That is not within our ethical authority. But again, it slides into the conversation, and it's our job to make sure that we keep a very firm limit on realizing what our role is and what it is not. Here, both of you, either one.
On a related thing, something in your last sentence which you triggered the particular question. There's a whole variety of them, starting with the way the Tom mentioned at the end. Contingency management, where you pay somebody, pay to play, pay to not misbehave.
Yep.
And people, including PhD researchers on NIH review panels, down to my neighbors at the neighborhood barbecue, have incredible and very stiff moral get their backs up against
Absolutely.
that kind of behavior. And there's a lot of research that shows it works in many places. And I never quite know how to respond. Somebody asked you for language, and I didn't hear if there was language in there. Like, how do you, I guess, there's something in what you said was, we're here to help and prescribe, but not to use, not to coerce behavior.
Yes.
But this one now actually sounds like it does coerce behavior, perhaps.
Well, let me add a little more language then. So here's what might help. So here's part of what people start to get muddy around pay-for-play kinds of schemes and the ability of paying people to alter their behavior in certain ways. And the truth is it will be ethically acceptable in some cases and not in others. And here's the line. Here's how we make those distinguished decisions. So when we talk about coercion in general, coercion is the use of force to get people to do whatever it is we want them to do. In fact, when we talk about what's the purpose of a government, all that the purpose of a government is who should have a justified use of coercion, right? Like what they have the ability to lock us in a prison and to take our money, and you and I don't have that authority, and so something has to justify that, and when should they use it? So when we talk about coercion, we're always talking about power imbalances. Someone has the ability to alter your behavior, either through controlling the kinds of circumstances you find yourself in, or by physically forcing you to do something, or by controlling your access to something you really want. Now, there's a close relative to coercion that's more close to the cases you're worried about. The technical term for what we discuss there is terms of exploitation. And so when we talk about offering financial incentives, well, exploitation is a form of coercion where instead of me giving you a poor consequence, instead of me saying, rob this bank or I'll shoot you, what I'm doing is I'm taking advantage of your already poor situation. So when we talk about why is there a minimum wage? So many people argue, well, of course, aren't you just better off if you have a job? You can work and you're making money versus nothing. Isn't that fabulous? Well, except all of us have to pay the bills. And so if your choice is starvation or working for a very, very low amount, you'll work for the low amount. So exploitation is a way to take advantage of a situation. So when we see that, a classic example of medical exploitation are kidney towns. So places internationally where we allow the buying and selling of organs on the foreign market. As of a few years ago, India just cracked down on this, but up until then, there were destinations where vast majorities of people in villages had sold at least one kidney. Some people were so desperate they sold both to feed their families. So what happened is, if you're very, very, very poor off, and I say, look, I'm giving you $2,500 for your kidney, many people argue, well, what's the harm? I'm giving you something you wouldn't otherwise have access to. Isn't that wonderful? But I'm offering you something that you're not in a position to refuse. So when I talk about altering people's behavior versus incentives, so is it okay for all of us to go to work and get a paycheck? Is that a sense of paying to alter our behavior? Yes, right? And why is that morally permissible? It's because we can choose not to. The problem is when we work with vulnerable populations, especially in a research context, especially about groups that are systematically disadvantaged, right? Now I'm talking about treading in very dangerous waters to avoid additional exploitation. And so the question is what I'm offering them sufficient that they're not making a fully independent choice? And that's why it's concerning. I'm exploiting a situation that they find themselves in.
That sounds like what the IRB gets at when they tell us we can't pay too much to.
It is.
In the study. And I just kind of feel bad because I can afford to turn down the minimal amount the IRB does let us pay. But the people that participate in our studies frequently can't even afford to turn that down. And all it sounds like is it's a maximum wage instead of a minimum wage.
Well, so full disclosure, I've been involved in appealing IRB decisions like that many times here. And one of the reasons is because this is where I editorialize slightly. Most people on IRBs aren't ethicists. They have no training in this. And so there's no training in the science, there's no training in the ethics. And what that means is that the results are very unpredictable. And that's problematic. We should all maybe worry. Here and then here. Go for it.
So just the first note on the compensatory behavior, I think we'll see more data coming out from practice as opposed to from the kind of efficacy trials that'll show that there's going to be sort of two groups of people. One group will actually increase or improve their protective behaviors, and another group will actually have that disinhibition. And
Yeah.
we see, and we won't see necessarily HIV infections because if they're here, they're protected from HIV infections, but we're going to see STI
That's right.
infections. And those may not be life-threatening and they're treatable, but they certainly have negative consequences, particularly for women's reproductive health.
That's right.
Over the long term, and also costs to the healthcare system and so on. And so on aggregate, we might see that those two groups balance each other out.
Absolutely.
Right, but that doesn't, in terms of like disease transmission and networks and epidemiology, we might see that there's kind of more STI outbreaks, and there could be more virulent kinds of STIs or different kinds of STIs. We haven't even identified.
Absolutely.
Now on the
Oh, yes.
potential problem. So that changes the balance of the equation. Like, what costs are you considering in that one portion of the cost utility component?
Well, so one of the reasons that those numbers are so unreliable is for that exact reason. The truth is we don't actually know what those numbers are going to look like when a larger segment of the population engages in whatever is going to happen next, behavior-wise. And maybe it will mean no increased risk of infections and no change, and maybe it will involve an increased risk of other infections, non-HIV infections. The question is this: whether that's true or not, whatever the data shows, should that bear into our decision-making process when we decide whether to prescribe PrEP? And the answer is going to most likely be no. What our obligation is then is to track whatever happens and to treat, but not to say that you are not deserving of this kind of protection, because I think that it will lead to bad consequences for you or others.
And then that brings me to thinking about alternatives. So what are the alternative technologies and options to PrEP or to anything? And if you have limited resources and your dollars are being
Oh, yes.
right
So
moved to the pharmaceutical
that's right.
prevention, and then you have no more investment in behavioral side, and then there's a whole question of what are the people say the behavioral intervention stuff is not feasible or useful because it's so expensive to have staff and so on and so forth. You have to train people. These programs are difficult to implement, and so it seems like that's justifying PrEP over behavioral. but I don't think it's an either or.
Oh, it's not. And we haven't even started to discuss the genetic research, right? And research on that level. And so there's questions that have to do with science hours in a lab. There's questions that have to do with staff that do behavioral interventions, and there's questions about the actual pharmacological interventions. So when we talk about utility, when most of these people give their charts about cost effectiveness, what they're doing is just looking at how the pie is cut up now and saying, I could additionally cut some from what's already being distributed here and put it here. That, of course, is an artificially constrained question. And so once I start looking at the much larger question, what I have to do is the same task that we just did, but on a much larger scale with more data. There are questions, too, about how much we should allocate to HIV treatment and prevention versus other diseases. The good news is this is all doable. There are actual answers that we can come up with that are not based on arbitrary assumptions or emotional appeals. But what it requires is being very honest about why we're choosing to focus on one kind of intervention and one population over another, and not necessarily just going with whoever is setting the agenda because they're donating the most money. And that's sort of taking how this kind of population level research works away from being a following kind of industry into a leading industry that says this is where our duty is. And I think that, to be honest, the entire industry of academics, scientists, researchers, and clinicians who work on HIV in particular have demonstrated that. So this has been one of the main areas where other kinds of scientific, I'm going to say people who desire to work on various kinds of population or individual diseases, this has been a model for what it looks like when interdisciplinary people come together and say, we have a moral obligation to work on this. And that's very exciting. But the problem is it's not happening in many other fields. And that's the task. How do I become very honest about what I'm working on, and more importantly, why I'm taking this approach? And so certainly, I need to have the same conversation discussing behavior.
Yeah, and then just the last point on the alternatives is the economic vulnerability. So we have more evidence showing that the people who are most marginalized, most at risk in terms of not being able to negotiate economy support, et cetera, are financially, food, housing, financial.
It all goes together.
So should we be considering alternatives like, well, $1,500 a month for PrEP, or $1,500 a month in an entitlement or a subsidy to mitigate your economic, food, housing, and security?
Yes.
That's going to put you in the position to...
That would be a yes. But that's exactly the kind of questions we have to talk about. What's happened historically is that when you have people working in isolation, not working collaboratively, you end up seeing problems with only the solution of one's particular discipline. So we talk about PrEP in a very narrow problem outside the context of who are the people that need PrEP, and is there something they need more? And let's talk about how to discuss that. And that's precisely the conversation we should be having. And we're working, hopefully, towards it. That's the goal. Yes?
Yeah, I just wanted to pick up on your comment on oral contraceptives and women, and I'm thinking of women in sub-Saharan Africa who traditionally actually have not been using oral contraceptives for a variety of reasons, including contraceptive sabotage, distance to facilities.
Absolutely.
All these sort of power dynamics, even of trying to use that, and also with spouses being away for long periods of time, so it just doesn't seem right to be taking that oral contraception. Secondly, I also wanted to raise the issue of that for that population in Africa, we know that women actually have more HIV than men in the younger ages.
Yep.
So when you're talking about some kind of trade-off, then it's not necessarily beneficial to women because they may be very much the ones who need to get onto the medication.
Certainly in that population. Right. Although depending on the kinds of populations, so of course it's not homogenous. Obviously, so South Africa is one of the regions that there's been the most amount of protest for women who desire PrEP and who are at high risk for being exposed to HIV. So one of the ways I got involved in this particular research in this area was I was contacted by researchers who were worried about the advocacy. Basically, people in South Africa, organization groups, were asking them to suspend the kind of research they were doing and start to worry about PrEP and start to deliver PrEP. And we wanted to have an ethics talk about whether the fact that a population is requesting it so strongly should sway us, whether that should be something that is sort of at the forefront of our work, or whether we should do other kinds of tasks. So here, there's a population where the hormonal contraception mattered a lot. It was a group that used it a lot. Now, when we have populations for whom that's not relevant, absolutely. The question of what to do then for this group that obviously the fact that this is consistent with hormonal contraceptive isn't the most interesting part, but we still have a group that is disadvantaged. And so what's going to be the answer for this group? Probably focus on antiretrovirals. Probably focus on therapeutic levels, that we can give medication to people who are already infected. And how do I think about that? I think about, what is my just obligation? What do I owe to each individual population, and why? And so here's a group. The reason that the levels of infection are so high are socially related. It's because of power imbalances. It's not accidental. And so do I owe this group perhaps particular care in treatment? Yes. Is PrEP the best treatment for them? Probably not. That's what it means, though, to move out of the aggregate. Instead of moving from a general level of saying, well, of course, in that case, we should give all women PrEP. Well, in this population, that would not be the thing that helps them in particular the most. So that's our job, to try to think about, obviously, we have to think about things at a population level, but to realize that that's not the only way we're obligated to think about it. We also want to worry about what the particulars look like. And you give an excellent example of that.
I have a question. When you teach about utility and urgent need, I think about the TA treatment as a prevention and PrEP, because both of these methods can stop the epidemic too. So my question is, can we compare the utility between these methods?
Absolutely. So the problem with utility, and the problem with thinking about just about effectiveness, is that I have to always think of that coupled with something else. And the something else is, what is my actual obligation and what is my actual goal here, right? And so long as I understand what the task is I'm aiming at, and it will never be to maximize efficiency, to maximize utility, because there are really horrific ways to do that, right? There are always going to be a very horrific way that's easier. So obviously, everything we do when it comes to efficiency is tempered. And so the question is, think about, what's the goal?
Because I think in US it's easy because you have tests and you have PrEP. But in some country, if they have to, which budget that they should put the money on between tests, treatment as prevention or PrEP?
Exactly. Well, part of it is going to be, one, what does the population want? And part of it is going to be, what is particularly suited for the demographic that I'm working with? And if I have an extraordinarily limited resource, I have an extraordinarily limited amount of money to distribute, then how do I think about why the patterns of this disease are what they are, right? It's not accidental. Why certain populations are more vulnerable to this than others. And that's part of the decision that I make when I think about how to spend my limited resources. Does that make sense?
Yes, thank you.
My pleasure. All right, thank you. Thank you very much.